Hello. Uh, I'm going to speak about glycogen storage disease today. You know that glycogen is a very important molecule. Basically, this is also sometimes called as the animal starch because this is the form in which human beings store carbohydrates. Otherwise, we don't store carbohydrates at all. Looking at the objectives of this lecture, basically what is expected from student to know at the end of this lecture is they should know the pathophysiology of the disease, the enzymes that are involved, the sign and symptoms that you see in the patients, and how to diagnose and treat them. So these are the basic things that we expect, or the outcome of this lecture should be that students should be able to answer all these things easily. Uh, if you look at glycogen storage disease, also known as glycogenosis or dextrinosis. Basically, it is a group of inherited disorders which is characterized by deposition of abnormal type or quantity of glycogen in liver, muscle, and other tissues. Conveniently, you can classify glycogen storage disease under two categories, that is, the liver glycogen storage disease and the muscle glycogen storage disease. As you see, the name itself suggests you are talking about the organ that is getting affected here, whether it is stored in liver or whether it is stored in the muscles. In US, you will see around one birth per 25,000 or one case per 25,000 births where the child might have glycogen storage disease. There are more than 15 types of glycogen storage disease, but basically, if you look at the most common types, we basically classify them into class 1 to class 6. If you look at glycogen storage disease, the type 1 is the most common one which you see. That is glucose 6 phosphatase deficiency, also known as type 1. Then you have got lysosomal acid alpha glucosidase deficiency, that is known as type 2. There is debranching enzyme deficiency, that is type 3, branching enzyme deficiency, that is type 4, myophosphorylase or muscle phosphorylase deficiency, that is type 5, and you have got glycogen phosphorylase deficiency, that is type 6. So let us look at what all these disorders are about. If you look at glycogen, you will see that if you are looking at the synthesis part for glycogen, you have few enzymes which are important for the glycogen synthesis. The first one is phosphoglucomutase. Then you have got glycogen synthase. You have got branching enzyme. On the other hand, if you are looking at the breakdown, you will see glycogen phosphorylase, debranching enzyme, phosphoglucomutase, and glucose 6 phosphate. So these are the important enzymes which are required for the synthesis and breakdown of glycogen. You start your glycogen synthesis with glucose molecule. You convert this glucose to glucose 6 phosphate, and then with the help of phosphoglucomutase, you convert it into glucose 1 phosphate. UDP glucose acts as a carrier for you. Every time you need a free glucose, UDP glucose is going to bring back the glucose for you. And that is how you slowly go on making a glycogen molecule. When you look at the breakdown, you start with glycogen. The enzyme that is required is glycogen phosphorylase. Glycogen phosphorylase is going to break 1,4 linkages for you. Then comes the debranching enzyme. That is where you have this glucose 1 phosphate being produced, which has to be converted into glucose 6 phosphate with the help of phosphoglucomutase. And in the end, glucose 6 phosphate to free glucose that comes because of glucose 6 phosphatase. So this is the basic idea. The basic reason behind putting this slide here is before we go in for the glycogen breakdown disorders, let us see how the structure of glycogen is and what all enzymes are important for making and breaking glycogen. Because it is due to the deficiency of any one of these enzymes that you start seeing some form of glycogen storage disease. So either you are not able to make it properly, or if you have made it, you are not able to break them properly. So this is what we are going to look in today's lecture. The most common type of all of the glycogen storage disease that you see is the type 1, also known as glucose 6 phosphatase. deficiency or the translocase deficiency. This another name for this disease is von Gerk's disease. This is the most common of all the glycogen storage diseases. It is an autosomal recessive disorder. What happens in this condition is you have impaired ability to synthesize glucose from glycogen and also from gluconeogenesis. So these are basically two major pathways that you see when you look at the synthesis of glucose. Either you make it from glycogen or you do gluconeogenesis, that is making glucose from non-carbohydrate sources. But when you look at type 1, you will see that both of these processes, that is synthesis of glucose from glycogen or generating a glucose from non-carbohydrate source, they both are getting affected. The outcome is fasting ketotic hypoglycemia. Keep this in mind, it is fasting ketotic hypoglycemia. What you are going to see is reduced glycogen utilization, and that's why you will also see enlargement of liver as well as kidney. The reason, you will have storage of glycogen in the liver, and that leads to hepatomegaly. There are two various different types when you talk about type 1 disease, that is type 1A, that is 80% of the cases you will see that the person is having deficiency for the enzyme glucose 6 phosphatase. There is another type that is known as glycogen storage disease type 1B. Around 20% of the population will have type 1B, and this is where you will have deficiency for the translocase. Actually, if you want to break glucose 6 phosphate, you have to go in the endoplasmic reticulum to break this. And that is where you require a translocase. This is the transporter that takes glucose 6 phosphate from the cytosol into the ER. And if you miss on this, you are not going to send glucose 6 phosphate in, and hence you are not going to break it. So these are two major types that you'll see. So let us see what the von Gerk's disease type 1 is. It results because of mutation in glucose 6 phosphatase. The gene for glucose 6 phosphatase is G6PC. GSD1B results because of mutation in the gene of T1 protein, that is translocase for the glucose 6 phosphate transporter. Glucose 6 phosphate from cytoplasm to the lumen of the endoplasmic reticulum is taken with the help of uh, this translocase. So if you are missing on the translocate or if you are missing on the enzyme, the outcome is going to be same. That is, you are not going to break glucose 6 phosphate. Uh, if you look at the clinical and laboratory features, there are a few distinct features that you see when you are looking at glucose 1 phosphate, glucose 6 phosphatase deficiency. That is, you will have doll-like face with fatty cheeks, relatively thin extremities as well as short stature. You will also see a very unique thing here, and that is the protrusion of abdomen, and that is due to massive hepatomegaly. Kidneys are also found to be enlarged, but spleen and heart, they remain normal. Remember, we are talking about liver storage disease, or it's a type of glycogen storage disease where liver is involved, and that's why you see hepatomegaly, but you don't see anything different when you look at the heart. If you look at the hepatocytes, they are distended by glycogen along with fats, and you will see hyperlipidemia, including elevation of triglycerides as well as cholesterol and phospholipids in these cases. What happens in this condition is you are not able to maintain sufficient blood glucose level during the post-absorptive states each day. So that is why, if you remember, the first slide we talked about was fasting hypoketotic hypoglycemia. Organ changes are going to be there because of glycogen accumulation. Excessive lactic acid is getting generated. You will also have damage to tissues from hyperuricemia. If you look at type 1B, you will see that there is bleeding as well as infection risk from neutropenia as well as neutrophil dysfunctioning. Treatment is diagnosis to maintain the treatment is designed to maintain the normal blood glucose level, and it is achieved by continuous nasogastric infusion of glucose or frequent oral administration of uncooked cornstarch. Allopurinol is given to lower your uric acid levels. For hyperlipidemias, you can reduce or you can treat them by giving the lipid lowering agents like HMG CoA reductase inhibitors, you have statins in that category. Uh, there is something also you should remember here when you are talking about glycogen storage disease, why this disease gives you hyperuricemia. Um, Most of the cases you will see that conditions where phosphate is getting blocked or trapped, not blocked, trapped. That is where you have glucose 6 phosphatase deficiency, or you talk about the fructose 1,6 phosphatase deficiency or galactose 6 phosphate 1 phosphate deficiency, galactose 1 phosphate uridyl transferase deficiency. All of these conditions, one thing is common, that your phosphate gets trapped. And when you have a trapped phosphate, you are not going to generate sufficient amount of ATPs. And when ATPs are not being formed, automatically you will see that your purine catabolism increases, and that leads to generation of excess amount of uric acid in your system, and that is why you have hyperuricemia in these cases.